devoted to share knowledge about pulmonary hypertension, to empower patients and caregivers to deal with that disease, and to bring in prestigious experts of that disease. And today we will talk about chronic thromboembolic pulmonary hypertension, or CTEPH, which is a rare form of pulmonary hypertension. And I'm honored to be joined today by two prestigious experts on CTEPH. That's Professor Marion Delcroix from the UZ Leuven and in Belgium, and Professor Javier Jais from Paris Hospital. And as always, we will hear first the presentations of our experts, and then you can participate by joining and writing questions and comments to the chat. And I'm happy to bring that in the discussion later on. So we will start with Professor Marion Delcroix. Dr. Delcroix, please, the floor is yours.
No. Okay, thank you for the introduction. And so I will start with the introduction on chronic thromboembolic hypertension, and I will go until the diagnosis, and then Xavier will deal with the treatment. And so what is CTEPH? What is the disease? First, we have the pH classification that you have explored already, and chronic thromboembolic hypertension is part of the fourth group of the pH classification. And what is the definition of the disease? So it is precapillary pulmonary hypertension. So it means that we have normally normal wedge pressure, and we have a mean pressure which is above 20 millimeters of mercury. We have abnormal imaging, which is first a ventilation perfusion scan showing mismatched perfusion defect, and we have abnormal CT scan and or angiography showing also typical finding of CTEPH, which I will show you later on. Normally, we wait 3 months of anticoagulation in order to not be confused by pulmonary embolism, acute pulmonary embolism, which could be on its own or also above chronic thromboembolic pulmonary hypertension. So we have spoken about CTEPH until now, but during the last guidelines meeting, we decided to adopt the concept of chronic thromboembolic pulmonary disease, because we also see patients who don't have pulmonary hypertension, but who have the same symptoms, who are short of breath, and also the same imaging with, again, mismatched perfusion defects and abnormal CT scan. And they don't have pulmonary hypertension at rest, but they probably develop pulmonary hypertension during exercise. And that's why it was important also to take this entity into account. Now, most of the patients, and I mean, in the registry, we find around 75% of the patients who have a history of acute pulmonary embolism, massive or repeated most frequently. And what you can see is that we see here that it's most frequently start with a clot, which is in the lower limbs, so what is called the deep venous thrombosis. It then embolizes to the lungs and come into the pulmonary artery. And most of the times, which means that 97% of the patients have a very good systems to dissolve these clots. But in some patients, around 3%, according to the statistics, we see that these clots, which you can recognize here, are transformed into fibrothrombotic material, which is a bit like you have like a piece of beefsteak in the vessels. And that has been to be treated completely differently with an operation which is called pulmonary endarterectomy, and this is the results of the surgery. So what we see in this disease are normally a three-compartment model where we see obstruction of the very large pulmonary artery close to the heart, and then distal branches. The pulmonary vascular tree is like a tree, and so we have the big branches, and then we have the small branches, and at the end we have the leaves, which are like the very small vessels, which is called microvascular circulation, and this can also be diseased, and this is the same disease that we see then in pulmonary arterial hypertension. So as I told you, we see around 3% of the patients after acute pulmonary embolism, in more precisely 2.7% of the patients who will have a diagnosis of chronic thromboembolic pulmonary hypertension. This number increases if you have a pulmonary embolism without any cause, without any embolization, and also 3 times more if you have a recurrence of venous thromboembolism, and even 7 times more, so we got to 21%, if you have any sign of right ventricle dysfunction, which is right ventricle which is dilated and working poorly. And this is very strong data, as we have studies who together have studied more than 10,000 patients. Now, another important findings is that we see many patients who have chronic thromboembolic pulmonary hypertension, but when they are presenting, they are first identified as having acute pulmonary embolism. And so it is important that at the moment if the patients have acute pulmonary embolism, which is a frequent disease, we have good evaluation by echocardiography and by CT, and that if we see pulmonary hypertension at that time, at the acute moment, this is already indication that we could probably face a patients who have already had pulmonary embolism before and recognized and treated and now have chronic thromboembolic pulmonary hypertension. And we have also a very importance of at the CT imaging, at the radiology imaging, that we look also for signs of chronic obstruction and a dilated right heart. Chronic vessel obstruction is difficult to recognize if you are not an experienced radiologist or PH specialist, because you need to look for the signs. If you don't, you can miss the diagnosis. And so CTEPH is rare, but probably under diagnosis. So we see in the registries that have been conducted until now that we have around 6 patients per million inhabitants each year diagnosed with CTEPH. This is already 3 times more than patients with idiopathic PH diagnosis per year. But when we go for the number of patients who have an acute PE, and we look at the incidence and we multiply that by 3%, we can go up to 17 cases per million inhabitants, which is 3 times more. And you would say, okay, this is just a calculation, but when we have very good follow-up of patients with acute PE, like has been performed in the population of the Sheffield City in UK, you see that they already get 12 cases per million inhabitants per year. So if you look for the patients, you find the patients. And so now what are the mechanisms of this unresolved pulmonary embolism? So we see that we have abnormal clot formation and dissolution. We have inflammation and infection, so probably plays a role in the persistence of the clots. We see that patients who don't have a spleen, which was removed most frequently because of a trauma, they have also an increased prevalence of CTEPH. We see also that normally you see here small vessels who are recanalizing the obstructed vessel, which is seen here. When you have a deficient proliferation of this vessel recanalizing the clots, you can have a more persistent disease. And we also see that some genetic anomalies of the coagulation can be involved in the disease mechanism. Anyway, we don't know exactly what is the primary trigger and what is the association of these different anomaly to make that the clots don't resolve. This is still under investigation. What we see also, this is big clots remaining, and this is fibrotic material. But we see that when we have this obstruction in the large vessels, we have the part of the lung which is not obstructed, which is exposed to high pressure and high blood flow. And so this will lead to what we call vascular remodeling. Probably in other webinars, you have seen that remodeling is a characteristic of idiopathic PAH, small vessels who getting increased wall thickness. And this is what we see here. This is the same lesion that you see in idiopathic PAH, and you see here, this is still an opened vessel, but you see that there is this sort of dead tree aspect. The branches are fine and not as extended as you would expect, and this is the result of the microvasculopathy caused by this abnormal flow. So this can make also that the disease that the patients are going to deteriorate, because of this long-term exposure of these vessels to high pressure. Now, what about the diagnosis? So we have symptoms which are described here. So this is a registry with around 700 patients. You see that the time from symptoms to diagnose is more than 1 year. And this can be reduced, of course, if you do a proper follow-up of patients with acute pulmonary embolism. And that the most frequent signs is shortness of breath. You know that one of the first moments where you experience shortness of breath is when you climb the stairs. We also see that patients have edema, swelling of the legs, fatigue, syncope is more rare, and we see a small percentage of the patients who have hemoptysis. What is hemoptysis? This is when you have expectoration which contains some blood. Now, in the guidelines, we had a diagnostic algorithm. So this is a structure how to proceed for the diagnosis of CTEPH, and we will go more in depth. So the first thing we have, the first population where we can find chronic thromboembolic pulmonary hypertension is the patients who are referred for pulmonary hypertension. So you have pulmonary hypertension, one of the first things we will do is look if you don't have chronic thromboembolic pulmonary hypertension. And this we do with perfusion imaging, which is a ventilation perfusion scan, which I already alluded to when I spoke about the definition of the disease. And these are mismatched perfusion defect. What does it mean? So you have here small images of this ventilation perfusion scan, where you see that when you compare the perfusion, so this is a blood stream, and here the ventilation, so this is the radioactivity coming through the airways, you see that there are discrepancies. Here, for example, you have a normal left lung, but you have no perfusion in most of these left lung. So this is highly abnormal, and you see here also very small, what we call segmental defects, which are not found on the ventilation. So this is very suggestive for CTEPH. So when we see such a patient, we send him to a specific CTEPH center. Now, we have also taken into account that there is a lot of research now in new modality for perfusion, because for doing that, you need to have radioactivity isotopes, and the production of them is becoming difficult, expensive, and this is not available anymore in all countries. So we have looked if the CT scan, which is a very classical examination, can also help to find this perfusion defect. And you see here two techniques, which is a dual energy CT, and this is subtraction, iodine subtraction technique, in order to find zones which are not perfused as well. So this is a well-perfused zone. This is an under-perfused zone of the lung. And you see here also holes where there is no perfusion. So these are things which we can use, but this is not yet validated as a good screening tool. This is very well validated. This is at this time more in the hands of the experts, but it will probably come, and probably the artificial intelligence will help us to have a standardized protocol of this CT scan. The second population we have here is the patients who have had an acute pulmonary embolism and who are followed for that. So which means 3 to 6 months after an acute pulmonary embolism, we see the patients, we ask them for their symptoms, and if they have persistent or new onset shortness of breath of exercise limitation, we have to go further for the diagnostic evaluation for chronic thromboembolic pulmonary hypertension. And you see here probably things you will see also in Xavier's presentation, which are the recommendation, which are what we have to do according to the guidelines. A class 1 means that it is a very strong recommendation, so this is what we need to do. And C is that is not proven, this is based on expert opinion. A or a B would be the results of very controlled studies. So if we have this patient after good PE, so we need to go further. And again, one of the first examination you do afterwards is a VQ scan. If this VQ scan is abnormal, showing defects, we send the patients to a CTEPH center for further evaluation. So this is for all cardiologists and pulmonologists. The next step are for the centers. When I say the next step, they come here, but also we want to know if the patients have pulmonary hypertension, and you know that the screening tool for pulmonary hypertension is echocardiography. And then we see if there are signs of pulmonary hypertension, which are increased pressure, dilated right heart. And so this is something probably you have seen in previous webinars. If we don't have pulmonary hypertension, we can also have some stress tests. If the patients have symptoms at exercise, we can repeat this exercise on a bike, doing what we call an ergospirometry, which is looking at the exercise characteristics of the patients. We can also do echo at exercise. And if it is abnormal, showing very high pressure, we probably have to follow the patient on the same way that the patients who have pulmonary hypertension at echography. Now, the next step is, as I told you, to send the patients to a CTEPH center, and there will happen the further investigation, which means we have to prove then the pulmonary hypertension, which is the right heart catheterization, and then we do more sophisticated imaging. Frequently, we get the CT scan picture already from the referring centers who have already proceeded to this part. And sometimes they are good quality, so we can do something with it. Sometimes it's poor quality or not sufficiently precise, and we need to repeat. If the CT is not conclusive for us, we do also an angiography. An angiography directly is like you have the right heart catheterization, the catheter is coming into the pulmonary artery, and then you inject some contrast and you see the splitting of the vessels and the occlusion. So these two techniques are a bit complementary. With the CT, you see more what is inside the vessels and the outside, where the angiography show you more the obstruction. So when we have this imaging and the proof that there is pulmonary hypertension at the catheterization, we confirm the diagnosis of chronic thromboembolic pulmonary hypertension, and then we need to move to the treatment assessment. And for there, we have the multidisciplinary team, and this will be detailed by Xavier in the next presentation. I just want you to show here some imaging of a typical case. So this is these clots in the large arteries. You see also material here on the left side, on the right side. When you do another way of cutting the images, you see here this enormous thrombi on both sides. This is really a dramatic case of chronic thromboembolic pulmonary hypertension. And this is the angiography. For the angiography, you see there is a catheter which is in the pulmonary artery injecting the contrast. This is for your comparison a normal vascular tree with all these branches going up to the periphery of the lung. And this is a case with chronic thromboembolic pulmonary hypertension, where you see there is here a very small branch where there should be a large branch. And here also on the down, you see that there are branches missing. Here also you see there is something which is not a normal caliber, and then there is a post-stenotic dilation. And here you see also the lack of branches on the left side. No branches is going to the periphery of the lung. When we have more precise imaging, this is something which is the angiography that you see here, but there are new techniques again also with the CT. This is a cone beam CT, where you see more detail of the anomaly, and you see what we typically describe in chronic thromboembolic hypertension, the web, which is such a structure, and then the tail or a slit, which is obstructing further down the vessels. And when we have a piece of the lung, we can see this architecture of the web and of the tail. So for the treatment, Xavier will help you. I just want to put the scene, which is 15 years ago, we had only surgery. And sorry. So we have today surgery, balloon dilatation, medical therapy, and the combination of them, and you will have a detailed approach to that. I want also to point out that I frequently refer to the CTEPH center. What is a CTEPH center? It is first a PH center, where you have a structure of doctors who are member of this multidisciplinary team, and then you have extended team where you have, in function of CTEPH, the need or a cardiothoracic surgeon, for example, and radiologist. We also need to see that the process needed for the quality are implemented, and a multidisciplinary team meeting is crucial in pulmonary hypertension, but even more in chronic thromboembolic pulmonary hypertension. We need to have quality controls, and you, of course, need to have patient empowerment, explaining very well to the patients what they need to do. And perhaps you have seen this document, which is the lay version of the guidelines for patients, which has been put together by the Open Lung Foundation. And you see that PH centers should provide care by team of experts. This is explained in this document. And more specifically for chronic thromboembolic pulmonary hypertension, there is the need of having people composing this multidisciplinary team, we will see further, which are trained in high volume centers. You don't improvise you as a PA surgeon or BPA interventionist. And there are also some requirements in volume of the activities, the number of surgery you do, the number of angioplasty you do. Of course, these figures are sometimes difficult to reach in smaller countries, but this is what we have to tend to. And so here you have my conclusion. CTEPH is a rare complication of pulmonary hypertension. Why the clots don't always resolve is still unknown. The exact incidence and prevalence are unknown, should be between 5 and 17 cases per million inhabitants per year. It is frequently misdiagnosed as having acute PE, so it's very important to follow the patient and to recognize early the signs of chronic clots. The risk factors, while most of the time an acute PE is at the origin of the disease, but we have also a small percentage of the population who don't have a history of acute PE and who have other conditions like splenectomy, but this represents a very small number of patients. And finally, the diagnosis, we request mandatory VQ scan, echo, catheterization, CT scan, and sometimes pulmonary angiography. Thank you for your attention.
Yeah, thank you very much, Dr. Delcroix, for this very insightful and comprehensive presentation on the pathology itself. A couple of questions certainly arise from your presentation, but before raising them, we go to Professor Jais, who will talk about the multidisciplinary and multi-professional approach. Javier, you can, if you don't mind, you can share your screen. Dr. Jais?
Yes, I'm sorry, but I have some technical issues, so I have to switch off my webcam because my connection is unstable, so
right.
I'm sorry
No
for
problem.
that.
We can hear you loud and clear. That's more important.
Mario, I think that you have to stop sharing your screen because...
She did.
Okay. So... Okay.
Here we go. Very good. Thanks very much. And
so
we are...
can move on to...
Your flow is yours.
So Thank you very much. Good afternoon, everybody. So it's my pleasure to present the management strategy for CTEPH. This is my disclosure statement. So the first step, when the diagnosis of CTEPH is confirmed, the first treatment that should be proposed is lifelong therapeutic anticoagulation, which is recommended for all patients with CTEPH. The goal of anticoagulation is to prevent the formation of new blood clots. So usually vitamin K antagonists are the standard of care for CTEPH, but now non-vitamin K oral anticoagulants are increasingly being used. However, it has been demonstrated in some studies that non-vitamin K oral anticoagulants are less effective than VKAs in antiphospholipid syndrome, which is a syndrome with autoantibodies increasing the risk of pulmonary embolism, and it is observed in approximately 10% of patients. So for this patient with antiphospholipid syndrome, anticoagulation with VKAs is recommended. So if we summarize, lifelong therapeutic dose of anticoagulation are recommended in all patients with CTEPH, and antiphospholipid syndrome testing is recommended in patients with CTEPH. So the next step, has been already mentioned by Marion, is the treatment assessment during a multidisciplinary team meeting. So it is recommended that all patients should be reviewed by a CTEPH team for the assessment of multimodality management. So the CTEPH team should include at least a surgeon performing pulmonary endarterectomy, a specialist in pulmonary hypertension, a thoracic radiologist, and an interventionist performing balloon pulmonary angioplasty. So what is the rationale for multimodal therapy? As it has been already mentioned by Marion, there are different lesions that can be observed in chronic thromboembolic pulmonary hypertension. You may have a proximal fibrotic obstruction in the large vessels. You can also have a fibrotic obstruction of the small vessel and also remodeling of the very small vessel, which is called a microvasculopathy. And if we look at the three available treatments that can be proposed for the management of CTEPH, you can observe that each treatment will target different lesions at different levels of the pulmonary vasculature. So if we look first at pulmonary endarterectomy, pulmonary endarterectomy is the recommended treatment for patients with CTEPH and fibrotic obstruction within pulmonary arteries accessible by surgery. So it means that if there is an obstruction of the large vessel and up to the segmental level, pulmonary endarterectomy is the treatment of choice. Balloon pulmonary angioplasty, it is recommended in patients who are technically operable. So it means patients who have fibrotic obstruction involving the small vessel, the segmental and the subsegmental vessels. And this is the principle of balloon pulmonary angioplasty. You have a vessel with an organized thrombus with some organized channel. So you put a balloon in one of these channels, you inflate the balloon, and the organized thrombus is compressed to one side. So the lumen is open wide by dissection of the media wall, and it can restore the blood flow after the obstruction. So what about medical therapy? So medical therapy will target microvasculopathy. It means the pulmonary vascular remodeling. And the treatment used in CTEPH are the same as those who are used in idiopathic PAH. So you have three different pathways, and you may have you have the endothelin pathway, and you have some treatment that target the endothelin pathway, and the antagonist, endothelin receptor antagonist, are the treatments that may be used to target the endothelin pathway. You have also the nitric oxide pathway, and you have two drugs, sildenafil, which is a PDE5 inhibitor, or riociguat, which is a guanylate cyclase stimulator, and the last pathway in the prostacyclin pathway, and you have treprostinil and selexipag. So if we look at the treatment algorithm, so the treatment that should be recommended for a patient, the first step is to assess the operability. And if the patient is considered as operable, the treatment of choice is pulmonary endarterectomy. So pulmonary endarterectomy is a surgery. So the operation necessitates general anesthesia and a midline sternotomy incision to expose the heart. Cardiopulmonary bypass is required to divert most of the blood from the heart and lungs and provide perfusion of oxygenated blood to the body. It is also mandatory to have a complete arrest of the circulation to facilitate the surgery, and also a deep hypothermia to reduce the metabolic rate and protect vital organs. So the surgery is performed through sternotomy, and each artery is open. I mean the main artery, the right main artery and the left main artery, and you introduce a dissector between the pulmonary artery wall and the fibrotic tissue, and then the fibrotic material is freed from the wall and removed with a special forceps. You have a special forceps. So what is the outcome after surgery? So it has been demonstrated in many studies that pulmonary endarterectomy improved symptoms, exercise capacity, and quality of life. It also leads to a decrease in pulmonary pressure and resistance to blood flow in the pulmonary arteries, and the survival at 3 years in patients who have been operated is 94%. So it is very important to reevaluate the patient after surgery, because some of patients may have persistent symptomatic pulmonary hypertension after surgery. So a few reminders regarding what is persistent symptomatic pulmonary hypertension. Symptomatic pulmonary hypertension are patients who have pulmonary hypertension with a WHO functional class 2 to 4. So patients with slight limitation of physical activity for patients in functional class 2 and for patients in functional class 4 with the inability to carry out any physical activity without symptoms. So which patient should be offered medical therapy and or balloon pulmonary angioplasty after surgery? So in this study, a team has evaluated the outcome 3 to 6 months after surgery. And what they observed that 85% of patients were in functional class 1 or 2, 3 to 6 months after surgery. But if we look at the pressure after surgery, more than 75% of patients had still pulmonary hypertension. I mean, mean PAP of more than 20 millimeters of mercury. And then they observe what are the thresholds regarding the mean pulmonary artery pressure, which is correlated with a worse long-term outcome. And what they observe that patients who had mean PAP of more than 38 millimeters of mercury after surgery had a worse long-term survival. So for this patient, it is very important to propose an additional treatment with medical therapy and or balloon pulmonary angioplasty. So it is very important to improve survival after surgery, so especially in patients with mean PAP of more than 38 millimeters of mercury, but it is also very important to improve symptoms in patients with persistent symptomatic pulmonary hypertension. So you may consider add-on therapy, I mean an additional treatment with medical therapy or BPA if patients are still symptomatic. So if they are in functional class 2 to 4, and if they have a mean PAP of more than 25 millimeters of mercury with PVR of more than 3 Wood units. So in this situation, the only treatment which is approved is riociguat, which is the patient with persistent pulmonary hypertension after surgery. Treprostinil, which is a prostacyclin analog, may be also considered in patients in WHO functional 3 to 4 who have also persistent pulmonary hypertension after surgery. So what about the combination of medical therapy and BPA after surgery in patients who are still symptomatic and have persistent pulmonary hypertension after surgery? If we look at the result of some study, you can see that the combination of medical therapy and balloon pulmonary angioplasty in patients with persistent symptomatic pulmonary hypertension after surgery is a very effective combination, with a significant decrease in the resistance to blood flow in the pulmonary artery, and the combination of these two treatments also improve symptoms, exercise capacity, and the quality of life. So what about the management of inoperable patients, so patients that could not be operated because the clots are located in the small pulmonary arteries. In this situation, the two recommended treatment is medical therapy and balloon pulmonary angioplasty. So regarding medical therapy, riociguat is also the recommended treatment for patients with inoperable CTEPH with a very high class of recommendation. Treprostinil may be also considered in a patient in WHO functional class 3 to 4 who have inoperable CTEPH. Off-label use of drugs approved for PAH, it means bosentan, macitentan, sildenafil, or riociguat, may be considered in symptomatic patients who have inoperable CTEPH, but you can see that the class of recommendation is lower than the class of recommendation for riociguat, which is the first-line treatment that should be proposed. And in patients with inoperable CTEPH, a combination of two treatments, it means a combination of PDE5 inhibitor plus endothelin receptor antagonist may be also considered in patients with inoperable CTEPH with a class 2B recommendation, which is lower than the class 1 recommendation for riociguat. So if we summarize, the first-line treatment that should be proposed for patients with inoperable CTEPH is riociguat or BPA with the same class of recommendation, a very high class of recommendation. We have now two studies who had compared BPA versus riociguat in patients with inoperable CTEPH. We have a French study, the RAY study, and a Japanese study, the MR-BPA study, and both studies have demonstrated the superiority of BPA over riociguat in decreasing both pulmonary pressure and resistance to blood flow in the pulmonary arteries. However, in the two studies, we observed that the treatment-related adverse events were more common with BPA than with riociguat. So what are the treatment adverse events for patients who underwent a BPA? So the complications related to BPA are now well known, and the main complication is vascular injury. It means that when you put the wire to put the balloon to dilate the vessel, you can have an injury, a perforation, or if you inflate the balloon in a small pulmonary artery, you may have also a rupture with a bleeding around the vessel due to the perforation of the vessel or the rupture of the vessel. So the severity of hemodynamics predicts BPA-related complication, and when patients have high pulmonary pressure and resistance to blood flow in the pulmonary arteries, it is associated with a higher risk of BPA-related complication. So we demonstrated in the RAISE trial, which was the French trial comparing BPA versus riociguat, that the use of riociguat prior to BPA may reduce the risk of BPA-related complication. And as you can observe, patients who are treated with first-line BPA have a higher risk of BPA-related complication, and the patients who are treated first with riociguat for 6 months had a lower risk of having a BPA-related complication. The complications were divided by 3 when you use medical treatment with riociguat prior to BPA. So it is recommended that medical therapy now should be considered prior to the intervention in patients who are candidate for BPA. So what about the outcome with the combination of riociguat and BPA in patients with inoperable CTEPH? It has been demonstrated in some studies that the combination of riociguat and BPA also improve symptoms, exercise capacity, and quality of life, and is also associated with a significant decrease in pulmonary pressures and resistance to blood flow in the pulmonary arteries. And if we look at the survival at 3 years in patients who have been treated with a combination of riociguat and BPA, you can observe that the survival at 3 years was 93%, which is similar to what we observe with surgery. So, what about the treatment goals and the follow-up? There is no consensus on what is the therapeutic goal after BPR or pulmonary endarterectomy or medical therapy. But most experts accept that achieving a good functional class, I mean a functional class 1 or 2, and a normalization or near normalization of hemodynamics at rest obtained 3 to 6 months post-procedure is maybe a good therapeutic goal. So the follow-up is very important after each procedure, BPA, pulmonary endarterectomy, medical therapy, and follow-up should include right heart catheterization 3 to 6 months after each intervention, pulmonary endarterectomy or last balloon pulmonary angioplasty. And after successful treatment, so when a patient is in functional class 1 with a normalization or near normalization of hemodynamics, it means a mean pulmonary pressure near 20 millimeters of mercury and resistance to blood flow in pulmonary arteries near to 3 Wood units. A yearly non-invasive follow-up is required with echography and evaluation of exercise capacity. So this is the treatment algorithm in 2023. So the first step is to evaluate during a multidisciplinary team meeting the operability. If a patient is considered as operable, pulmonary endarterectomy is the treatment of choice. Patients should be re-evaluated 3 to 6 months after surgery to look if there is a persistent symptomatic pulmonary hypertension. If it is the case, you can discuss to propose to the patient to have an additional treatment with medical therapy and balloon pulmonary angioplasty. For patients who are considered as non-operable, most of them will be treated first with medical therapy with riociguat, and then a BPA will be proposed to patient in the majority of cases. And it is very important to have a long-term follow-up in a CTEPH center to reassess the efficacy of each treatment at each step of the management of the patient. Thank you for your attention.
Yeah, thank you very much, Dr. Jais, for that very important presentation on the multimodal approach for CTEPH. And actually, we have a couple of questions from our audience. And one is actually in how many, whether you know how many countries have actually adapted that new multimodal, or that we should say state-of-the-art multimodal approach as you presented it. Dr. Jais, Javier Jais.
I'm sorry, I can't hear you. I have.
Okay, you can't hear me? Okay. Then probably Dr. Delcroix, can you answer that question? I mean, the question was how many countries have that multimodal approach be implemented?
Well, the problem is for many centers the access to the technical approaches. Surgery is difficult in many countries. That's why we see also an increased number of patients who go to BPA because that looks easier. But that doesn't prove that this is a good strategy. So we really need to promote the education of surgeons for many of the countries. Now, in the problem is also that even in the countries where you have access to surgery, you see a bigger trend for centers to do balloon angioplasty because they have the possibility to do it because they have expertise in coronary angioplasty, but that's absolutely not the same, and so we have to fair the cardiologists who perform this approach without being integrated in a multidisciplinary team, because in function of the lesions, you have to give a different solution to the patient. So it's very important to have in the same center the interventional cardiologist or radiologist, the surgeon, and the PH specialist, and to have a common approach to the disease. That makes it so difficult that we need to have the expertise in the three domains of the treatment, and which requires so very dedicated centers, and not each cardiology can start doing that. So, but the access to education is very open in Europe and in the US. You can go easily to specialist centers and learn the techniques if there is no center in your country.
Right. I mean, we learned from your presentation, Dr. Delcroix, that the CTEPH is underdiagnosed, so it's often overseen. That's one hurdle for the patients, of course, and one barrier to appropriate treatment without proper diagnosis. And how, according to your experience, how easy it is for patients to be referred really to a CTEPH center that is that can apply that multimodal approach?
Mm-hmm. Well, it depends, I would say, from ethical consideration also. I know in my own country, it's very difficult for patients, for doctors to refer patients sometimes, because there is such a concept of the ownership of patients. So it is your patients, you have made the diagnosis, and it stays your patients. And so the refer process in the medical domain is something we don't pay sufficient attention to. And so you have countries who are very centralized, very well organized, like France, but you have also countries like the US where you can have people dealing with rare disease, even in the smallest place, not referring patients. So that's very difficult, and I think patients have a big role in that. That they should make some social control on the hospital, telling, okay, this is not normal that you treat patients while you don't have the required expertise.
Yeah, and that's actually also the purpose of the Alliance for Pulmonary Hypertension, to empower patients and to help them finding their way, although this may be sometimes very difficult. We have a couple of other questions. How many sessions of BPA are necessary on average to obtain satisfactory results?
So statistically, we see that most centers do 4 or 5 sessions. During each session, they target different vessels, but for security reason, it has been initially, and in most centers are doing first one lung, in order, if you have bleeding, that not 2 lungs are full of blood, so that there is always one lung which is good. And then if you have to block the bleeding with any other technique, you still have a lung which is functioning good. In Japan, where they have the largest expertise, you see that they sometimes do small intervention in nearly all the vessels, and then when there is the next sessions, they go with bigger balloons. So there are different ways to approach the intervention, and so globally we see 4 to 5 sessions.
All right.
But sometimes specific patients may need up to 9 sessions.
Dr. Jais, can you hear us? Javier Jais, can you hear us? Well, apparently not. So I, unfortunately, after your great presentation, probably I missed that. But let me assure, because we have a question: how many patients need pH medication after pH and after BPA, respectively? Do we have that information? Are there good data on that? Javier Jais, can you hear us? I got the message that he's in the audio stream, but Dr. Lacroix, probably you can. Yeah.
So how many patients need? So this is a difficult question. After surgery, we frequently told that the patient was cured, and that there was no need of further follow-up of intervention. But with the years, we have seen that they are not completely cured. They can have a significant improvement in exercise capacity and in the pressure we measure, but still that's not perfect. And they've still reduced in comparison with normal. And we more and more follow these patients and do additional treatment afterwards, which can be BPA or medication. We see that probably half of the patients after surgery have still a low level of pulmonary hypertension. And this is a question still unknown. What is the hemodynamic value when you need to start a medical of BPA treatment? This is a bit uncertain currently. But I would say that probably after surgery, you could imagine that 20% of the patients would require treatment and to 20% medical treatment. And after BPA, that's less of a question because they were started with medications before having the BPA. And that is more the questions, when can we stop the medication?
And we have also a question, and I guess the answer may be yes. Is it possible to recommend pre-angioplastic medical treatment for all patients? I think Dr. Jais has mentioned that.
Well, that's what we do in Europe. I know that in Japan, for a significant proportion of the patients, they do only BPA. But that's more a regional approach.
Okay. Actually, are there any genetic risk factors for CTEPH?
Well, there are risk factors for thrombosis, genetic risk factor for thrombosis, which are the factor V Leiden mutation and the prothrombin mutation. But this doesn't translate immediately in a risk for CTEPH. And for CTEPH, we have done genome-wide analysis in order to find specific mutation, but we didn't find them. There is an association with blood group location. So the location on the genes would determine the blood group. There is something which seems to influence, but it's not really a single gene disease as we can have for patients with BMPR2 mutation, for example. So this is a bit more tricky to find the genetic context. But we also don't see really families of patients with CTEPH.
Right.
I don't know if Xavier is back here, if he's in Paris familiar with CTEPH.
Xavier?
Yes, I changed my computer. It's better now. Yeah, I'm sorry.
No problem.
Technical issue with yes. So I can't hear your question, Marion. Sorry.
If I was telling that we don't see families of patients with CTEPH. that. Do you have some families in Paris where you had operated on different member of the family?
We have only one family, yes. Where I think 2 members of the family develop CTEPH and were operated, yes, but only one family.
So there may be a mixture of genetic background and non-genetic background?
Maybe, but we test the patient and we did not find anything, right. So we don't know. Yes.
Right. Basically, as we are running out of time, the final question is, why sometimes do specialists only realize after many years that what they thought a PAH is in fact a CTEPH?
Well, we have seen in surveys that some countries and in some PH centers, in the broad sense of the word, they don't perform systematic VQ scan. And that has been a cause of late recognition of CTEPH. And that's dramatic because CTEPH is much more curable than PAH. And so we strongly encourage all the centers to have at least a perfusion imaging to be sure they don't miss CTEPH.
Thanks very much for your time, Dr. Delcroix, Dr. Jais, and for all the listeners. This webinar will be made available very soon on the AFPH knowledge sharing platform. So you can listen to it. Again, you can share it with others. We will meet again in December, on the 12th of December, for the 6th and last webinar for this year. And that's about the rise of pulmonary hypertension patient associations and their role in today's care landscape. Thanks very much for listening, and have a great evening or great day wherever you are well listening to. Thank you very much. Bye.
Thank you.
Thank you. Bye.